Ladies and gentlemen, thank you very much for coming today. Today we have Dr. Nathan Radcliffe, who is from the New York University as well as New York Eye Surgery Center, and he is also has extensive experience with the Cyclo G6 glaucoma laser system using the MicroPulse P3 probe. And so that's what he will be speaking about today. So, ladies and gentlemen, help me welcome Dr. Nathan Radcliffe.
Well, thank you, Mike. Am I okay on the audio here? You can hear me? Okay. Well, it's a pleasure to be here. This has been sort of an exciting experience for me to be performing this laser. We just heard from Rob Noecker. If I'm not mistaken, he was the first maybe to do MicroPulse here in the US, and maybe I was the second. So I have now more than 2 years of experience with the laser. I think I've treated several hundred patients, and happy to be talking about that experience because it's pretty fantastic for our patients. Either someone's making a really loud espresso over there, or there's some gas leak or something. It looks like they have it under control. All right, I have some financial disclosures here, and Iridex is among them. I'm going to talk a little bit about MicroPulse laser, what it is, how it works. If I have one main point to make, I'll spoil it right now, which is that this laser is a tool that you can use to address a wide variety of glaucoma problems. It's incredibly versatile, and it's titratable. And we titrate the laser by knowing our patients and knowing how the laser works and using it very thoughtfully. And by doing so, we have great success. So, you know, there's a gap in glaucoma care. We have medicines that are relatively safe but lack profound efficacy. And we have surgeries that can be profoundly efficacious but in some cases lack safety. So that's the gap. We know glaucoma is a disease that progresses over time and that it's pressure dependent. Here's sort of my glaucoma landscape. We have meds and laser, and in that context I kind of mean SLT laser. Cataract surgery is a pressure lowering therapy. We have the eye stent, which is great for early glaucoma. Some other angle procedures, Visco 360, the Cahook blade, other things. We will soon have CyPass, suprachoroidal shunt. It's actually FDA approved and rolling out as we speak at this meeting. And endocyclophotocoagulation is also a therapy that decreases the production of aqueous humor. And then for the severe glaucoma, we have the Almond valve. I would suggest that MicroPulse fits many of this spectrum. You're not necessarily using it as a primary therapy before an eye drop, but you can use it early in the disease. You can use it in the MIGS space, along with cataract surgery and other MIGS devices, and you can use it for very severe glaucomas. And for me, my experience began with the very severe glaucomas and working my way back towards the earlier glaucomas once I had a good experience with the laser. Again, I think what we're doing with MicroPulse is taking that inexorable relationship between if it's safe, it's not effective, and if it's effective, it's not safe, and we're decreasing the gain on that relationship a little bit. I think it's always going to be somewhat true in glaucoma. So, you know, what's the real solution for managing glaucoma? We want control of the therapy. It has to be efficient. It has to be, or it's nice if it's repeatable. Along with repeatability is not being precluded by any other surgery. For example, many would say you can't do a trabeculectomy if you've already done a tube. You can't do an eye stent if someone's already done a suture canaloplasty. There are some procedures that knock out others just by having been performed, and this one is not one of them. It can be performed before or after any other surgery. So this is the laser. Obviously, Iridex has many of them around. And are you going to loop the video, or do you have video looping of the actual procedure itself? Yeah. So I'm not going to spend too much time talking about the actual performing of the procedure, except to say that it's very straightforward. I'll describe it a little bit, but The concept behind MicroPulse is its versatility, provide this efficient, straightforward procedure. But what's the technology? Well, you're taking a continuous laser and you're breaking it up into small pieces. The analogy that I use is, it's like the anti-lock brake. Rather than having the brake or the wheel stop entirely, skidding, losing control, the MicroPulse titrates the laser into very short bursts, a half a millisecond of laser application, and then followed by a rest, maybe a 1.1 millisecond rest, and then a laser and a rest. And 56,000 times during a treatment, you will cycle between rest and laser. And what that does is it pulses the tissue, but without causing massive thermal accumulation and collateral damage. So it's being delivered in a little bit more of a controlled manner, without thermal destruction of tissue, and ideally you're getting more of a biologic response than a destructive or coagulative necrosis of the tissue. So we use the term the duty cycle to describe the percentage of time that the laser is on. Okay, so if it's a half a millisecond on and then 1.1 milliseconds off, it's something like a 31% duty cycle. And that's what we use for MicroPulse currently. So what's the technique? Well, we have a probe, and it's similar to the G probe, but with some modifications. It's more of just a straight tip. There's no sort of horn, if you will, as you see on the G probe. So this is more circular. It has one flat edge, which we usually put towards the limbus. And you anesthetize the eye, and you treat around the eye, sparing the 3 and 9 o'clock. We're not entirely sure that you need to spare the 3 and 9 o'clock. The original concept there was with transscleral cyclophotocoagulation with continuous laser. You would spare because you have tissues and arteries and nerves there. I spare those areas because I have efficacy if I spare, and so I'm not feeling like there's a problem sparing those areas. And it's thought to be safer because you avoid the vascular and the neurovascular bundle. Contrast that to the G probe, where you would do single applications, and you do maybe 14 or 15 around the eye. With the MicroPulse, we just slowly rotate the eye, or rotate the probe on the eye over the course of, say, 50 or 80 seconds for the treatment. Okay. I'm going to talk a little bit about how I break down the dosage and all that, so I'll get back to this. Well, you can see some destruction with traditional transscleral cyclophotocoagulation. With MicroPulse, you don't. I have actually hooked the MicroPulse up to an endoscope and performed MicroPulse viewing the ciliary processes as the laser was applied, and I didn't see any thermal change the way you see contraction and even sometimes explosion with traditional endoscopic cyclophotocoagulation. So I think, or I do believe, this is a different mechanism and we're not causing explosions. Have I ever heard a pop during a MicroPulse? I have, using it at higher doses in certain situations, but never at 2,000 milliwatts, which is usually what we're using. It's different than traditional transscleral cyclophotocoagulation. And I'll show you several data sets, and I think I can go, I'll go right to a 78-month long study. So these are patients who were treated and have now been followed for many years, and 6.5 years, 43% pressure reduction. So that's profound pressure reduction. We often see 20%, we see 25, 30%, 43% is in the same level of efficacy as a Barvelt glaucoma drainage device or trabeculectomy. There's always a question of how durable a therapy is, and I think this study shows that it's a durable therapy. We do occasionally repeat the laser, and I always say that's one of the good things about it is we can repeat it. There's no reason not to, and so we can start with doses that we know are exceptionally safe and use higher doses later if the patient doesn't respond. And I talk to the patients about that and how I'm intentionally picking my laser dose along those lines. Rob Noecker and I had our group of patients. This is just 3-month data, and we probably need to take a look at it because it's been over a year now. But we were getting 30% pressure reduction, and these were our first cases. So I probably get more than that now because I've changed some of my treatment parameters, and I'll discuss that with you. Here's a study from Marlene Moster, getting pressures down from 38 to 23 with her use of the laser, and getting patients off drops as well. 40% pressure reduction overall in her series, and decrease in medication. Some of the patients in her series had two treatments. All right. This study, I think, answers the question of MicroPulse versus the transscleral laser. Randomized controlled trial. Both had excellent pressure reduction. Okay. And with MicroPulse, actually, they had a higher pressure reduction, higher percentage of pressure reduction, or percentage of patients getting their pressure under 21. I think what's also important is that the hypotony only occurred in the traditional transscleral group. No patients getting MicroPulse have had profound hypotony. And that's consistent with my experience as well. So again, these are some of the advantages. So personally now I've treated over 200 patients. I do a number every week. And I'm getting a range of pressure reduction based on the patient's needs. In my practice, I practice in the Bronx of New York. There's very severe glaucoma there, a lot of it advanced stage. So it's not uncommon for me to have someone come in with a pressure of 70. And that's how you get 80% pressure reduction is, you give a very strong treatment and you can get them down to the teens or to 10. I've not seen ptysis, nor CME. And I would actually accept, you get CME from cataract surgery. I would accept some CME as any treatment that causes some inflammation, but I just haven't seen it. And I had a patient, whose vision worsened and there was a cataract, and you can see inflammation too. And I want to talk a little bit about my technique. This is a laser that's absorbed by pigment in the eye. And if someone has a very dark iris, their body will do a great job of absorbing that laser. If someone, and honestly, just generally how much pigment they have in their skin is also, I think, correlated to how well they absorb the laser energy. Patients with blue eyes, you can use higher doses of laser on because they're not going to absorb, just like when you're doing an argon iridectomy. I treated an albino patient once, and I don't think the therapy was particularly effective because there was no absorption of the laser. And I was aware of that going in, but there was silicone oil in the eye, and there aren't too many therapies you can offer that type of patient. The higher the pressure, the more aggressive I am with both the time of treatment and the actual dosage or power of the laser. If the patient has very severe disease, I'm more aggressive. And the visual acuity makes a difference. I do treat patients with 20/20 vision. And in those cases, I use the sort of standard settings, 2,000 milliwatts for 50 seconds on the top of the eye, and 2,000 milliwatts for 50 seconds on the bottom of the eye. I always use a retrobulbar block. There are surgeons out there who will use a parabulbar block, and there are surgeons out there who will, if they're doing it in an ASC, they'll have the patient just get their propofol, and then the laser's done by the time the propofol wears off, so that's a different approach. But for me, it's convenient in my ASC, or even in my office where I administer the block myself. So I have two offices. One's in the city, academic center. The other is a ASC up in the Bronx. In the Bronx, I do them in the ASC. In the office, I do them in the city. Or sorry, in the New York City office, I do them in the office and with a block that I administer. They both work great. Patients seem to be happy with either, and I think you could choose either one depending on what works best for your office. When I'm using lower doses or using the standard dose of 2,000 milliwatts, I'll often tell the patient this is a very safe dose of laser, and that's a great thing. If your glaucoma is more aggressive, I may come back and treat more, but this is where I want to start because I need to see how your eye responds. And I think it's just important to understand that some patients are prone a little bit more to inflammation, and other patients seem bulletproof, and you can be very aggressive with the laser, and it's good to know. Just talking a little bit about which patients I treat. Every patient has their own sort of narrative, and we can tailor this to the patient's story. Some patients prefer laser. For better or for worse, the thought of a needle being in their eye or cutting their eye is a problem for the patient. Elderly patients have done particularly well with this therapy. These are people who don't have anyone with them after they're going to go home for a surgery. I have some patients who can't have someone come to the operating room to pick them up after because they live alone. And those patients can be blocked in the office with lidocaine, perform the laser, and then lidocaine wears off and they can go home after you watch them in the office for a while. So that's an advantage. Had patients who've had horrible outcomes from traditional glaucoma surgery in one eye who need something different. I have had a particularly good experience with this laser after Ahmed valves. And these are Ahmed valves that still have a capsule. They're clearly working but have an encapsulated tube and high pressures. And they respond a little better to the laser than the same patient, same pressure, who's never had the tube. So for them, I always use 2,000 milliwatts, and I know I'll get a great pressure reduction, whereas that same person who hasn't had the tube, I might use a little bit of a higher laser setting. Patients with poor vision can have this laser with essentially no risk, and it can be very effective. And the discomfort associated with things like a tube shunt surgery, the prolonged recovery, are really a big deal, and it's a lot to put an eye through if the eye isn't seeing well, but perhaps has eye pain from high pressures. I use this to alleviate microcystic edema and ruptured bullae from high pressures in eyes that aren't well sighted. Very effective and provides great relief. And the one thing you may get is, if you've been medically managing a patient for 6 months, trying all sorts of different drops, Diamox, pilocarpine, and then you do this laser, you have to actually watch out, because I've had patients be angry at me for not doing the laser sooner. Wait, that's it? Laser's over. They go home. They come back 2 weeks later. Their pressure's low. Why have I been in here juggling eye drops, for the past 6 months? And sometimes I have a good answer, which is, well, I told you about the laser and you said you didn't want it. And then they say, okay. But sometimes it's really just my practice pattern not having evolved to the therapy that I have available. And if you think about Diamox, it's not the safest option we have. Pilo is not very well tolerated, and I use them every day. And this is an effective therapy that can be delivered. It takes a little shifting of our mental paradigms to be able to offer this, probably in the way it should be offered. Patients with blepharitis who look like they could be a risk for infection. Anytime I'm about to do an incisional glaucoma surgery on someone and they break out their eye drop bottle and it's like physically dirty, I'm less excited to have that patient have an incisional glaucoma surgery. Fall risk is a significant thing, and patients who are very unstable on their feet, will do better with a procedure that's not going to give them blurry vision for a couple of weeks. And as you know, if you've had a tube or a trab or any of those incisional surgeries, any pressure on the eye can be devastating. With this procedure, there's really no restriction and limitation in terms of activities. After the surgery's done, they can go do whatever it is they like. For better or for worse, my practice has become an eye cancer glaucoma practice. I have 2 busy cancer doctors in the city who send me eyes with both neovascular glaucoma and usually melanomas, and they're not candidates for outflow procedures, but do very well with this laser, and it's been a total blessing for those patients. These are some of the indications, and as you can see, it's a lot of different scenarios. Now, that's where you start, I think, is with these triggers, these difficult scenarios. Start with an eye with a pressure of 50 for your first case, where you're going for pain control. But eventually, you know, when you get experience using the laser, it can be offered to someone in lieu of a glaucoma surgery straight up, someone who hasn't failed another glaucoma surgery, and I think the safety and efficacy supports that use. One of the things I do see, because I've had the opportunity to teach a few colleagues, you know, is they'll do like 2 or 3 cases and be so blown away that the next week they'll book, you know, 10 cases. And I usually am saying, okay, I mean, that's great, but take it easy, slow down a little bit, because you'll get some inflammation. I want to talk about that and how to manage it and how to stay away from it. Just more data from Rob Noecker, and then I'll show a few cases. And this is a year old, I'm sure. He's treated more than 46 patients. But in this series, he had 26 pressure 26 at baseline down to 15, 41% pressure reduction. So you're seeing pretty consistent results from one practice to the next. He had no hypotony, and he retreated 12 people. So I think, to me, he's using the laser correctly, right? He hasn't brought anyone down into the low pressure range, and he's also clearly treating enough to get good efficacy, and he's had some retreatments. If he were treating so aggressively that he had no retreatments, you know, it's possible he could get some lower pressures. Let's see what we have here. 65-year-old vein occlusion in the right eye. It's been treated by retina. But the pressure's the vision's pretty good, 20/80. Pressure's 40 on everything, including Diamox. Treated with MicroPulse P3 in the office. So, in this case, I went a little higher than the standard 2,000 milliwatts. And I did that because the vision's slightly reduced. The pressure's very high, okay? So those two things make me feel like I can be a little bit more aggressive. And I use 50 seconds to the top, 50 seconds to the bottom, okay? No pain, patient did well, pressure's down to 10. Happens all the time, really good result. By the way, if the patient had already had an Ahmed in this case, I'd do 2,000 instead of 2,250. So just trying to get you a sense of how I might alter some of the dose. By the way, you feel free to email me if you have a case coming up and you're interested in hearing my thoughts on what laser settings I'd use. It's drradcliffe@gmail. Always happy to take those. Here's a 78-year-old woman with exfoliation glaucoma on the right eye. Pressure's 38. Pressure just flew out of control. Good vision, right eye, 20/40. So do I give the settings here? This is Rob's case. So he did 2,000 milliwatts, and 2,000 milliwatts for 80 seconds up top and 80 seconds down below, I think is Noecker's standard treatment. Yep. Got pressure 6 to 10, treated with Durezol. So what do we do to control inflammation during the procedure? I give a subconj injection of Solumedrol, dexamethasone, something short-acting, and that's to get ahead of any inflammation. And they're blocked, so it's well tolerated. And then I put them on prednisolone 4 times a day for a week. If it's someone with, 2200 vision, I don't see him in a week. I see him at 2 weeks, because I am convinced you have efficacy 100% by 2 weeks. If they're 20/20, I see them in a week, and it's because if they have any cells in the chamber, I would continue the pred or taper it. But usually I cold turkey after 1 week of QID. So I'm using the same amount of anti-inflammatory as I do with a SLT laser or an iridotomy for most people, with the exception of the bolus given during the laser. Here's one of my cases, 93-year-old, pressures in the mid-20s, 25, 29 on 4 meds. But look at this damage. It's really kind of central in the left eye and approaching the center in the right. So good vision in the right eye and a little bit of loss from glaucoma in the left. And we did the laser in both eyes a couple weeks apart. So again, I did in the right eye 100 seconds at a little bit higher, 2250. So I was being a little aggressive there, but she's on a lot of drops, and that is a 20/20 eye. but I felt she needed a little bit more. And I believe this was a Caucasian woman. And the reason that's important is, again, if she had a lot of pigment, I probably, in a 20/20 eye, would go with 2,000 milliwatts. In a fellow eye that's already losing glaucoma from fixation, I think you're justified in being a little more aggressive. I did 2,500 milliwatts and a longer duration. So you can play with these different parameters. One of the reasons I tend to go up on the laser is my experience, the laser power rather than the laser time, is my experience with endocyclophotocoagulation. When you do treat a process, you see the effect, and it happens very quickly. Holding the laser on the tissue for longer isn't visibly doing anything. Now, it might be a different mechanism. You might be getting uveoscleral outflow with MicroPulse rather than just decrease in aqueous production with endocyclophotocoagulation, but I still tend to titrate up the laser energy rather than sit on the eye for longer. And again, another fantastic response. And then here's the case I was explaining. Ahmed valve has been placed, but now the pressure's back up to 28 on 4 agents, 2200 eye. And I went aggressive here mainly because of the bad vision. 2200, there's very low risk in making this eye worse even with a heavy laser setting. Patients down to 1 drop and a pressure of 10. You know, what's probably missing from these cases is a person who was treated and didn't have much pressure reduction, and also didn't have any adverse events. And that patient's retreated with a higher laser setting. So, you know, that happens. You'd be ready for it. I think you can expect that. For me, I don't repeat the laser that often, but I think you might have a light response in 1 out of 10, some number like that. And that's because we're treating glaucoma here, and you know, if anything were 100%, it would be the only glaucoma procedure ever performed. Again, I use a retrobulbar block. Propofol can be used at the time of the block or not. In my office, I don't use propofol. Some folks will use a lubricant on the eye, like goniosol, just to be able to move the probe over the conjunctiva with more ease. I don't. Haven't had a problem with that. In some patients with a tight orbit or ptosis, it can be a little bit difficult to access the superior limbus with the probe, and in that case you may want to use a Q-tip to bring the eye down, but 1 in 20 cases for me. If you look in the literature, Paul Chu has the best data, longest data, and it's suggesting 2,000 milliwatts, 50 seconds up top, 50 seconds down bottom. And the MicroPulse duty cycle, 31%. We used a little bit more energy, and in some cases a little bit longer in our series. And again, everyone's using the same duty cycle, which is just preset on the MP3 device. Dr. Noecker will use Durezol. I tend to use Pred Forte when I treat. And you know, I'll follow up at 1 or 2 weeks depending on the patient. I see them at week 1 if they're 20/20. What do we see at day 1? I don't see the patients at day 1, but you know, we did at the beginning. You could have efficacy as soon as day 1, but not always. To me, it's not that critical to see them at day 1 because there's no management that I'm going to change based on where the pressure is. Even if the pressure remains high at day 1, you know, we've treated and we just need to give the treatment time. And at week 1, as I said, I'll either you'll see the pressure reduction. If there's no inflammation, you stop the pred. If there's a little cell, you will decrease. Very rarely, you know, 1% of the time maybe. And I've only seen it if I hadn't given the subconj steroid at the time of the laser. You can have fibrin in the anterior chamber, and that, to me, happened in patients who had a little bit of pigment. So a pigmented eye, dark brown iris, and on patients who I gave a heavy laser dose, maybe 2250 or 2500. And in those patients, you're just going to have to treat that fibrin with steroids until it goes away. By month 1, I think you'll know how well it worked. I have been willing to retreat as early, this question comes up, well, if you don't think it's working, how early would you retreat? I started very conservatively on that, giving it 3 months, 6 months before I decided to retreat. But now I think you don't have a risk of over-treating and getting hypotony if you retreat at 3 weeks or a month. I think if you have a high pressure and you didn't get the response you want, you could retreat probably as early as 2 or 3 weeks. Okay. So again, this is where we see things fitting in, to the MicroPulse. In terms of trabeculoplasty, that's a therapy I like. I tend to use trabeculoplasty to eliminate eye drop side effects, to eliminate high copays, to eliminate compliance problems. I tend to use SLT first line before I start a drop. I don't usually use SLT for someone who's got a rip-roaring uncontrolled eye pressure. So for me, you could take the same person with some moderate glaucoma, and if their pressure's controlled and I want to get them off a drop, I'd use SLT. If their pressure's not controlled, we might discuss MicroPulse for therapy. In the cases where I've done MicroPulse along with an eye stent or something else, I have in some cases used even lower laser settings than 2,000 milliwatts. I've done MicroPulse in combination with glaucoma drainage implants, so devices like Bearvelt or an Ahmed can give you short-term pressure control, which the Bearvelt doesn't give you. But in those cases, I tend to use lower doses because when the tube opens, I don't want to have hypotony, and I haven't had hypotony, but I haven't gone above 2,000 milliwatts if I'm combining it with a tube, even in pretty severe glaucoma. So I'll conclude here, and then happy to take any questions. But I think we've got a safe option for treating glaucoma here. Get to know the laser, and get to know your patients, and look at your responses, and then personalize, tailor, and titrate to the patient. We can address a lot of different stages of the disease, and ultimately what we're doing here is maintaining safety and delivering efficacy in a nice way. And one final thing I'll say is that you can do this procedure rapidly in the office. It does not slow you down if you're seeing patients. You can get a patient from consent to treatment probably in 10 minutes, if things are running well. You'll still spend a lot of time managing it and talking to the patient, but can be delivered rapidly, and for emergencies and in terms of patient flow, it delivers a good efficiency that I think is something that's much needed in practicing glaucoma in 2016. So with that, I'm happy to take any questions. Yep.
If you've had previous surgery like a trabeculoplasty or a stent, do you stay away from the area in treating the patient?
Right. So no. If I have a trabeculectomy and it's scarred, I'll just laser over it. If there's a bit of a bleb there, I'll usually avoid that. I will laser over a corneal patch graft from a tube, but if it's a pericardial patch graft, I tend to just avoid that little area. And so, yep. Yeah.
A couple of questions. First of all, I may have missed this earlier. How do you decide where to do the treatment in terms of, like, say, a myopic eye, non-myopic eye? Do you use a transilluminator to look at to find out what the ciliary body is, or?
This is a good question, and it's really interesting. It is helpful to use transillumination just to see the anatomy. I think we're going we want to go posterior to the iris root. We may want to get not just ciliary processes, but even a little bit posterior to that, and that's because the thought is that we're getting uveoscleral outflow through that tissue, and that the mechanism isn't destruction per se of the ciliary processes themselves. Now, I don't know, exactly where we're treating or where the effect is coming from. There's some evidence it might be uveoscleral outflow. So what I do typically is I find the limbus. There's a little bit of a flat edge on the probe. That's the one I have towards the limbus. And I move back maybe a millimeter from the limbus. So I'm not hugging the limbus. I do, in some cases you'll see a little bit of dry eye, and I think if you go too close, I don't want to get the limbal stem cells as part of this treatment. So I go a little bit posterior, and I get great efficacy there. I agree, some eyes, the anatomy's tricky, and it still is what it is, which is a ab externo procedure, but we still seem to do well.
And sorry, just a question. Oh yeah, and where do you stop when you're coming around, or do you just go 360? You don't really worry about
The 3 and 9.
Yeah, 3 and 9.
I probably skipped those two areas mostly out of superstition. One thing with safety, there have been a few rare cases of a dilated pupil after the laser's performed. I haven't seen it. I've had it reported to me. I don't know what causes that. I have a suspicion it could be treating, in those areas where you have nerves, but it's unclear. But the traditional reason to spare those areas because you have blood vessels and nerves, and leave them alone if you can. And since you still get the effect, we still want to, we'll still do what we can in the name of safety, I guess.
Have you had anybody with double vision after the procedure?
No, I haven't. And I suppose you could get that from the block or from the.
Maybe getting the blood vessels to the muscles, or.
Oh yeah, no, I haven't seen that. Just mainly some inflammation that had to be treated. As I said earlier, you may not have been here. No CME, no ptysis, and no hypotony with choroidals or anything like that. I've had plenty of patients with pressures in the single digits or the high single digits or the low teens.
Thank you.
Yep.
Any more? Oh.
Can you repeat the procedure and how many times you can repeat it?
I believe it's repeatable infinitely. If you think of it, there's no anatomical reason you can't keep repeating it. That's kind of the concept, is to titrate. It'd be very nice if you could, just keep retreating and find the perfect dose and just titrate everyone down, get everyone off drops, and do it slowly. I mean, obviously we can't be bringing patients in all the time. So I haven't treated anyone. Maybe I've treated one patient 3 times. I've treated a few patients twice. It's not, to me, is something I'm doing a lot of, but as you can see, when I get the chance, I increase the dose if I think it's safe to do so, and that's sort of my way. I think that I'm helping avoiding some of the retreatments. Is going above 2,000 milliwatts when I think it's very safe to do so.
Any more questions? Okay. Well, thank you very much. Thank you, Dr. Radcliffe, for your time.
Thank you.